Hi again, this is Frank Rhame, infectious disease physician at the Abbott Northwestern Hospital and the University of Minnesota in Minneapolis, Minnesota, bringing you now COVID and hepatitis. I'm going to, I like to start these, as you know, with an image of something that reminds me very much of the place that I'm speaking at. So what I picked here was the beautiful cranes you guys have. I thought about another beautiful bird, but I knew if I did that, I'd get myself in trouble, so I went back to the crane. So I'm going to do a couple things that apply to both decks because I've got a little more time in the hepatitis talk. So I just want to go over my disclosures. I do a lot of dancing with pharma, but maybe because I do enough of it, I do it with different people. I'm not beholden to any one of them in particular. And I'm talking about investigational drugs and off-label uses in both of these talks. This is me. I come from Minneapolis, which is a cold part of Minnesota, cold part of the world. We're at the headwaters, near the headwaters of the Mississippi River, which is our biggest river. And here it is. Here's the downtown Minneapolis and the University of Minnesota over to the right, and the Mississippi River right there. This is my hospital, Abbott Northwestern Hospital. My research clinic is just 2 blocks away from here. We're doing the COVID vaccine trial, which I've already talked about. This is where I live in the little yellow, little white oval, right over the falls. Beautiful location. So I want to point out that the images I've used in these talks are depicted here. I got one from Gilead, but most of the rest of them are for, simply speaking, CCO or EASL, the European Association for the Study of Liver Disease, study of the liver. This is the outline. Most of the simply speaking stuff is all about hepatitis C, although I'm going to use the AASLD guidelines for that. A little bit of hepatitis B, I'm going to use the EASL guideline for that, and not much about hepatitis D or hepatitis E, just don't have time. So the deck for, the simply speaking deck for hepatitis C is quite recent and pretty good, although I think the AASLD one is a bit better, partly because the, simply speaking, doesn't like to talk about specific drugs, and you really have to do that a bit. That's to simply speaking's credit, but in the real world we have to think about which drugs we're going to use. So this is the section of the special population deck that deals with hepatitis C. I'll do a couple images that are not so much related to disease, but some in the U.S., some in the globe. This is the U.S. Status with respect to reducing the rate of acute HIV infection, and on the right, the rate of deaths from hepatitis C infection. And you can see, compared to our goals, we're going the wrong way with respect to the incidence of hepatitis C. With respect to the rate of death, we're doing better than our goals, and that's because the drugs are so wonderful. So WHO not doing a lot better. Their targets are not being met, and their targets are ambitious. So I'll put 2 images in here that probably you're pretty familiar with. The first is the image of what hepatitis C is like if you do not become a chronic carrier. 20% of people do not become chronic carriers. They develop hepatitis C viral load, and then it disappears. They're antibody positive, and they stay antibody positive. So the people who are antibody positive get distinguished between this group, the people who don't establish chronic carriage, and the people who do establish chronic carriage by whether or not the HCV RNA persists. So when you get an antibody positive person, you then do the viral load and you find out whether they're in the fortunate 20% that cured themselves or the unfortunate percent that became chronic carriers. This is the algorithm that's being used by the CDC. If you do the antibody test for screening and they're non-reactive, you forget it. An exception to that might be if there's an immune globulin problem, if the person's immunosuppressed, you might want to go on and do a viral load in that situation. But that mostly, if they're antibody negative, you can forget it. If they're antibody positive, like over to the right, then you do the HCV RNA, and if it's detected, you got to get them in care. Big problem getting everybody who's got hepatitis C into care. And if they're not detected, you can pretty much let it go unless they have additional exposures. 2 images here that are relevant to the interaction between hepatitis C and HIV. And the first one is that people who are HIV positive seem to be much more likely to get hepatitis C than people who are HIV negative. These are two subsets of the cohort of gay men in Amsterdam, where the fraction that was HIV positive depicted there on the left in both of those images had a much higher rate of hepatitis C infection than the people, similar people who are HIV negative. Don't know why it's that strong, but there it is. We have to go with the data. So the Simply Speaking deck produces some resources. I'm going to turn to the AASLD IDSA guidance in the next image and go through it there. So I've got 7 images here to try to summarize the AASLD recommendations for straightforward cases. And we'll see at the last image here, there are a lot of special circumstances that you really are going to need to get a specialist involved in. But if it's a straightforward case, anybody can manage it. So the AASLD recommends that everyone should be tested at least once after they're 18 years old. And anybody else with ongoing exposure should have periodic testing thereafter. Pregnant women should be tested with every pregnancy. And people with HIV, with ID, drug abuse, MSMs, men on PrEP should be tested annually. And then you got to get them into care, which we don't do a terribly good job at. All right, when they arrive at your doorstep with an antibody test positive, you're going to be doing that HCV RNA level, of our load level. We reflex those from the first positive antibody test. You're going to do it again if they have recent exposure. You're going to do it if they're immunosuppressed and are having exposures. And we would do it again at the initiation of treatment if the previous one was done more than 6 months ago. We want to determine their hepatitis B, HIV, and HIV status, hepatitis B and hepatitis B and HIV, because we don't want people who have hepatitis C. We don't want their livers burdened with those two things. We want to get them vaccinated if they are susceptible. HIV, because it has some impact on the management, particularly the drug-drug interactions. We don't do HCV genotype anymore. The regimens we use now are pangenotypic. They hit all the genomes, so the only time we have to do that is when a payer makes us do it, which is a waste of money. We need to tell all our patients who are antibody positive and hepatitis C viral load negative, the cured group, either spontaneously or after drugs, that they can get hepatitis C again. So they must be aware of that. And then we make sure, just to start, we do an INR, complete blood count, a liver test, and a kidney function study. So after you've done that initial evaluation, you're going to vaccinate the people for hepatitis A or hepatitis B if they need it. You're going to warn people and importune them not to drink alcohol. We want to tell them what they need to do to not transmit, because they can transmit. We need to do an assessment of the fibrosis level. We do that with a FibroScan and APRI or a FIB4. Most of you will not have access to a FibroScan, but the APRI and the FIB4 can be done quite cheaply. And if they are cirrhotic, we need to make sure they're vaccinated against Streptococcus pneumoniae, because they have a high rate of streptococcal pneumococcal infection. So the adjunct treatments we do are just them. The initial treatment is discussed here. We do not do hepatitis C prophylaxis. We do not do post-exposure prophylaxis. But we treat everybody if we can, including the acutes. You need to assess the drug-drug interactions, particularly if they're on HIV meds. You need to control their HIV and their hepatitis B before you start the hepatitis C treatment. Not a long time before, but still a little bit before. There's an important issue about hepatitis B and hepatitis C co-infection, in that treating the hepatitis C infection in people who are co-infected for those two hepatitis viruses can actually aggravate the hepatitis B infection. Probably that's because hepatitis C inhibits the immune system. It actually gets into your immune cells and turns them off. And if we control hepatitis C, they get back to work and they will flare the hepatitis B. If they have advanced liver disease, we can't use one of the hepatitis C treatments that has a protease inhibitor. And it really boils down to 2 recommended regimens now. We have Harvoni and Mavyret, and they're pangenotypic. These are the drug-drug interactions. I'll just point out that the integrase inhibitors are the group here with the least level of interaction, and that's typically what we try to do with the HIV regimen if they are going to need hepatitis C treatment, get them on an integrase inhibitor. What do we do after we initiate treatment? During treatment, if they're on the regimen there, elbasvir and grazoprevir, we do a liver panel at 8 weeks and 16 weeks, 12 weeks if they're on a 16-week regimen. We don't do that often. If you happen to find out that their ALT level is more than 10 times the baseline level, then we stop therapy. You'd find this out if they got ill and you'd checked it, and that can happen. After treatment is over, you want to do a viral load more than 12 months after the end of treatment. That's how you define cure. And then if they are cirrhotic, you need to do hepatocellular carcinoma surveillance. We do a Q6 month right upper quadrant ultrasound for that. So these are the special situations. These are the reasons why, in fact, you do need specialists in this for these kinds of situations. Retreatment, decompensated cirrhosis, ribavirin use, some regimens require resistance in people who have failed treatment, pregnancy, after they've had a liver transplant, if it looks like they might have hepatocellular carcinoma, pediatric context, postpartum context. So there are some tricky bits there. So now I'm going to switch gears and finish with the easel slides on hepatitis B management. I put the whole easel deck in there, and I'm only going to pick out a few of the slides for it. Those of you who want to get farther into hepatitis B management can look at that. For many of you, hepatitis B treatment is kind of moot because tenofovir takes care of it. So your co-infected patients with HIV and hepatitis B, if they're on a tenofovir regimen, you don't really even think that hard about hepatitis B because the tenofovir is the best thing for it. So there's a useful, very useful in my mind, new division of hepatitis B situations. And what you can see there is the left-hand two columns are the people who are e antigen positive. The next two columns are the people who are e antigen negative, and then phase 5 over there to the right is people who have resolved infection. So the two subdivisions of each of the e antigen positive, e antigen negative pairs of columns are the people who have infection, and they have ongoing viral replication, but they don't have signs of hepatitis, and so they can have chronic hepatitis B, e antigen positive. Likewise for e antigen negatives, the third and fourth columns there, you can have just infection, which means the liver is not having a lot of damage, or you can have actual inflammation, the hepatitis, chronic hepatitis, as opposed to chronic infection in the e antigen negatives. So you can divide them up there. A key differential is whether they have elevated ALT or not, and the HBV DNA varies as well. And you can see that for the e antigen negatives, the threshold of worry is a bit lower, 2,000. So this is a quick picture of how things change over time through these different categories. You typically start e antigen negative and become e antigen positive, then you get to be e antigen, then you develop antibody. The wavy lines there are basically to show that there's variation in the key categories of HBV DNA, surface antigen, and ALT. So the goals of therapy, straightforward. You want to basically you want to control the virus, and here's the indications for treatment. The key thing here is for those of you treating hepatitis B monotherapy patients, not everybody needs to be treated. So the people who definitely should be treated are the e antigen positive or negative patients with chronic hepatitis as opposed to just infection, the patients with cirrhosis and any detectable HB DNA, and the patients with high levels of HB DNA and ALT regardless of anything else. So those are the people who really need it. So again, the reason why this is easy for those of you who are HIV treaters is because the rate of resistance to tenofovir, the two right-hand categories there, whether it be TAF or TDF, is nil. So for whatever reason, this violates my understanding of nature. People don't seem to get hepatitis B resistance to tenofovir. So if you got a patient on a tenofovir regimen, that's it. A lot of special groups, I'm not going to deal with those, but it's just to point out that you have, this is that issue of hepatitis C co-infection. So you need to monitor people who are co-infected with C and B because the C can flare, and so if you're treating C and they have B, most people will want to suppress the B before they treat the C. So that's it. I appreciate very much your time. I wish I were there, and I'll be available for questions from Minneapolis. Thank you.